liver and cardiovascular disease in NAFLD relevant to medical practice? Well, let's look at that. The answer is here. If you look at the mortality risk associated with no NAFLD, NAFLD, and NASH, you can see when you move from no NAFLD to NAFLD, the risk of dying from liver disease increases slightly, but the risk of dying from cardiovascular disease multiplies manyfold. And when you move from NAFLD to NASH, the risk of dying from liver disease also balloons up. And so many patients die from liver disease, and equally large number, if not more, die from cardiovascular disease. Also look at non-cardiac, non-cardiovascular causes, which also increase significantly when you move from no NAFLD to NAFLD and NASH, respectively. As you can see, the risk of dying from CKD, respiratory illnesses, malignancies, both hepatic and extrahepatic, increases tremendously. So yes, the topic allocated to me, fortunately, is very relevant to medical practice. I'll split this talk into two portions. First, predicting risk of liver disease in NAFLD, and second, predicting risk of cardiovascular disease in NAFLD. So first, predicting risk of liver disease in NAFLD. You know very well that normal liver to NAFL, where there is fat in the liver but no inflammation, no fibrosis, these are easy, relatively easy to handle. You can follow these patients up, provide them non-pharmacological management, particularly weight loss, and they would be followed up in your clinic maybe 6 to 12 monthly. But when you move to NASH and cirrhosis, the risks of dying from liver, cardiovascular, and other causes increases significantly. And this is what I'm going to talk about. I'm not going to discuss the etiology on this talk of NAFLD, but certain genetic association or genetic polymorphism in PNPLA3, TM6, SF2, GCKR, SOD2, and MBOT7 are strongly associated with liver disease. These polymorphisms in such genes have either neutral or inverse relationship with dying from cardiovascular disease. So one needs to remember the association of genetic polymorphism with cardiovascular and hepatic mortality. Also of importance are epigenetics, where the genes do not show any polymorphism, but the expression of genes is altered by some environmental factor, which in the context of NAFLD is gut microbiome. The dysbiosis, the increased or altered intestinal permeability, and the mediators which regulate the gut microbiota induce some changes in gene expression, which can lead to risk of NAFLD, and this is strongly associated with mortality from cardiovascular disease in NAFLD, as well as hepatic disease in NAFLD, unlike genetic association. So the million-dollar question is, if you have 100 patients in NAFLD, how many have NASH and how many have advanced fibrosis? And these are the two key factors which impact the future outcome and eventual mortality. So in this presentation, I'm going to talk about how to identify patients with NASH and also those with increased fibrosis. Fortunately, if we have 25% prevalence of NAFLD in a population, only about 3 to 5% have NASH, and only 1 to 3% have advanced fibrosis. But look at this chart. The higher the fibrosis, the higher the risk of dying if you follow them up over 1 to 4 decades. So minimal fibrosis or no fibrosis, the risk of dying is just the same as general population. But as the fibrosis increases to F2, F3, and F4, the risk of dying over the years increases proportionately. So this is the million-dollar question: how to identify NASH and higher degrees of fibrosis and cirrhosis in patients with NAFLD. The clinical predictors of NASH in patients with NAFLD are given here. They do not make a diagnosis, but they should alarm you that advanced age, male sex or postmenopausal women, certain races like Hispanics in US and Asian patients, those with metabolic syndrome, persistently high enzymes, particularly reversal of AST and ALT ratio, low platelets, and persistently elevated ALT are associated with NASH, and one should specifically keep them under surveillance and do more for such patients because they may have NASH, which will eventually progress to fibrosis and cirrhosis. Now, you know very well that we use various tools for the diagnosis of NAFLD, but as you can see here, liver enzymes are not very sensitive and specific. You may have normal liver enzymes in NASH, so they are not very sensitive and specific. And with low degrees of fat in the liver, ultrasound is not very sensitive. CT is similarly less sensitive, but more specific. MRI, again, if you use protein density fat fraction mode, it has high specificity but lowish sensitivity. And the best tool is MRS or MR elastography, which equates almost with liver biopsy in the diagnosis of NAFLD and NASH. Liver biopsy is considered to be the gold standard, but there are many problems with this, as we will see later on. So liver enzymes, ALT, AST, not sensitive for NAFLD or NASH. Non-invasive tests, well, there are many. I'm only going to put emphasis on APRI, FIB4, and NFS, NAFLD fibrosis score, because they are easier to do and do not require specialized tests. I'm not going to talk about FibroSure, ELF, HEPA score, etc., because again, the parameters that are needed for these tests are not commercially available in Pakistan and maybe in many countries around the world. FibroScan, I will certainly going to talk about it. MR elastography is not freely available, is expensive, and RFI has never found itself a place in the diagnosis of NASH and advanced fibrosis. Similarly, NIS4, Fibroscapt, Adapt Pro C3, and cytokeratin 18, I'm not going to talk about them because these tests are not commercially available in Pakistan. But something new, FAST, which incorporates AST, FibroScan, and CAP, controlled attenuation parameters, which most of the machines now have this software, and you can determine the fat in the liver. A combination of these tests by means of an app available on your smartphone has found to have some useful place in predicting fibrosis, steatosis, and inflammation in people with NAFLD. So remember, this FAST score can be easily calculated if you have CAP and FibroScan values with you. AST is always there. So proper use of non-invasive tests can aid, if not in diagnosing higher grade of fibrosis, at least excluding them. And I will just highlight that it is so easy. You have these calculators in your smartphone. You can easily calculate NAFLD fibrosis score and FIB4 scores, and they can help you in stratifying your patients, whether they have higher degrees of fibrosis or no fibrosis. They certainly, as I mentioned, help in excluding absence of advanced fibrosis, and in clear-cut cases, make a diagnosis of advanced fibrosis if the scores are high. But they are hampered by a lot of indeterminate cases, which you see with the use of such scoring systems. FibroScan is useful in ruling out advanced fibrosis, so it has a high negative predictive value. And if you have a score of less than 6 to 7, it is highly unlikely that your patient has advanced fibrosis. And you keep them as low risk and just follow them up and provide them general advice. Higher values increase the likelihood of more severe fibrosis, and which predicts the risk of decompensation and other complications associated with it. You must remember that overestimation of fibrosis can occur in hepatitis if there is raised ALT due to any cause, cholestasis, liver congestion, particularly in heart failure, and in obesity, you have to use the right probe to get the meaningful values. If the FibroScan values are 20 plus, it correlates very well with portal pressure, and it is used along with low platelets to screen patients for varices on endoscopy. Just to highlight that CAP is helpful. These are the cutoff values, and many of my patients are certainly motivated by seeing S3 values, which means more than 66% of liver is replaced by fat, and it gives them the motivation to lose weight and get rid of this fat. So CAP has its value and should not be underestimated in the evaluation of patients with NAFLD. Sequential use of non-invasive tests certainly goes a long way to reduce the number of indeterminate cases. So you use it once, call back your patient in 6 to 12 weeks, do it again, and you will find that it excludes or confirms fibrosis in more number of patients than the initial evaluation. So using all this information, low age, no diabetes, no obesity, low FibroScan values, low AST, low NFS and FIB4 scores indicate low likelihood of NASH and fibrosis. But on the other hand, if you have an elderly or older patient with diabetes, obesity, hypertension, higher KPA values, higher ALT, and higher values of NFS and FIB4, this has a high likelihood of NASH and fibrosis and would benefit from further workup. So it helps to identify patients who have high rate of fibrosis. And this is how we do. After using all this information, we select patients for liver biopsy. And high risk and those patients who are in indeterminate category may be helped by doing a liver biopsy. What does the liver biopsy do? It makes diagnosis of NASH, it stages fibrosis, and rules out any other disease which might have been missed, like autoimmune, Wilson's, DILI, iron overload, etc., in patients whom we are evaluating for NAFLD. The problem with liver biopsy is that it is invasive and painful, expensive, associated with morbidity and mortality, with sampling variability inter-observer variability. You need expertise to perform, and is impractical for population screening. Is a liver biopsy always necessary in NAFLD? Certainly not. It is not required if you can exclude higher degrees of fibrosis and stage disease and stratify risk progression by other means. It should be tailored to the individual patient where there are marked biochemical abnormalities on LFTs, diagnosis is in doubt, non-invasive scores that are high or indeterminate, and if the patient is willing to have it. So it has a role. I'll end the evaluation of liver disease predicting mortality by incorporating endohepatology as a one-stop solution for evaluation of patients with NAFLD. If you are a follower of Kenneth Chang from US, you will certainly know that in one session, you can screen for varices by doing EUS. You can do the shear wave elastography. You can obtain a good liver biopsy specimen using Francine or fork tip, whatever needle is available. And you can directly measure portal pressure and hepatic vein pressure and hence calculate HPPG. This is particularly useful in difficult patients with multiple comorbids who are being evaluated for some invasive procedure or surgery. And it will guide you and stratify the risk of surgery and whether the patient can undergo such difficult procedures or not. So something which will make its place more and more in the future, but certainly worth knowing that these are the steps whereby you can select which patients from NAFLD cohort have NASH and advanced fibrosis, and you can keep them services. Now, moving gear and predicting risk of cardiovascular disease in NAFLD. Is it important? Again, yes. The same slide that I showed you earlier, the risk of dying from cardiovascular disease balloons up as you move from no NAFLD to NAFLD. So it is important to stratify your patients with some means about the risk of cardiovascular disease. And both EASL and ASLD guidelines highlight that you should screen for cardiovascular disease and you should stratify risk of cardiovascular disease in patients with NAFLD. There is a lot of literature in support of risk assessment for cardiovascular disease in NAFLD and need to screen for it. I will not go into the details, but you can go through this, browse through the literature, and you will find there is sufficient data in literature to support this practice. What is the spectrum of cardiovascular disease in NAFLD? Well, almost everything can happen. Arrhythmias, valvular heart disease, autonomic dysfunction, cardiomyopathy, atherosclerotic cardiovascular disease, and cholecardia. I don't have time to talk about it, but certainly something which is coming up of interest for both hepatologists and cardiologists. What do I do? In my patients with NAFLD, I use one of these scoring systems, particularly ACC, AHA, cardiovascular risk stratifying score. All these systems use gender, age, cholesterol, HDL, blood pressure, whether on medication for blood pressure, smoking, diabetes, known cardiovascular disease, family history of cardiovascular disease, and Reynolds risk assessment also incorporates CRP, which in my opinion is important in terms of NAFLD. In future, you will see the addition of NAFLD and its scoring systems to these screening tools for cardiovascular disease because it is important. So I use a ACC scoring system for my patients with NAFLD. If I find a high score, I refer them to cardiologist. If they have low risk, I just follow them up. But for indeterminate or intermediate risk, I do recommend that if you have this coronary artery calcium scoring available, your CT, if this has the software to calculate coronary artery calcium score, it would be helpful. If you don't have it, you can rely on your risk scoring and start anti-hyperlipidemic treatment and refer high-risk patients to your cardiologist. If you calculate high calcium score on coronary artery calcium scoring on CT, you can pick up intermediate and high-risk patients to go to your cardiologist for further screening. So what do you do if risk of cardiovascular disease is moderate to high on stratification? I refer my patients with NAFLD with moderate or high risk of cardiovascular disease to cardiologist for further assessment and intervention. So in summary, Mr. Chairman, ladies and gentlemen, NAFLD and NASH is associated with high risk of liver-related